Good afternoon, everyone. I welcome you all to this first webinar of the members of this group, Clinical Audiology. And I have this absolute privilege and honor to talk about Dr. C.S. Vanaja, my teacher, my mentor for Diagnostic Audiology and Evoked Potentials. I do not want to introduce ma'am to you all because she needs no introduction. She is the highest riser among the few high rises in the field of evoked potentials in India. Ma'am is the stalwart of electrophysiology not only in India but in the audiology fraternity globally. She has several publications, has authored several chapters and edited several books in this area. Presently, ma'am is heading the School of Audiology and Speech Language Pathology at Bharati Vidyapeeth Deemed University, Pune. I will now hand over the platform to ma'am and welcome you all to ride this wave of cortical evoked potentials with her. Ma'am, the platform is all yours, ma'am.
And first of all, I would like to really appreciate Clinical Audiology Group and ISHA for organizing this webinar. And I think the active participants in the Clinical Audiology Group are Imran, Wasim, and Srividya. So I really appreciate their enthusiasm. I'm sorry I'm a very, I'm not really an active member of the WhatsApp group. I'm sorry about that part of it. But I really appreciate you people doing this webinar and giving me an opportunity to share my thoughts about it. So to start with, you people gave me a topic of introduction and clinical application was the topic that was given to me. So I've put it like saying, okay, cortical auditory evoked potentials, evidence for use in clinical practice. And the outline of the webinar is going to be like this, a very brief introduction about what cortical evoked potentials are and what are the generators of it. And the major focus is on the clinical application, both in terms of hearing assessment and in terms of oral rehabilitation. And when Srividya asked me how long it will take, I said 1 hour, but actually my slides are going a little longer. Achaya and Niraj, you can stop me anytime you think it's going too much. So to begin with, we all know that cortical evoked potentials were also called as auditory long latency response. These were the first auditory evoked potentials to be recorded from central nervous system. And the foundations of these CAEPs were laid by Pauline Davis and Hallowell Davis and their colleagues. And we have to pay a tribute to them to having initiated this and then gave us the foundation for these cortical evoked potentials. But we also know that though this was the first potential to be discovered, it did not really come into clinical practice for a long time. And we'll discuss why it did happen that way also. So now to say cortical evoked potentials is a very broad term because it includes obligatory responses as well as endogenous potentials or discriminator potentials as called by different people. That is, you have these obligatory responses which are P1, N1, P2, N2, and you also have the endogenous potentials like P300, MMN, N400, P500, and many. And the focus of this series is based on obligatory, is only for obligatory responses. So I'm sticking my talk only to obligatory responses. And the obligatory responses, like all of you know, includes 2 positive and 2 negative peaks, which are P1, N1, P2, and N2, which is also called as P60, N100, P160, and N200. So this is a typical cortical evoked potentials which can be recorded from a normal adult. So you can see here a positive peak, a negative, another positive peak, and a negative peak. And these cortical evoked potentials are generated obviously by auditory cortex. So the cortical potentials have multiple generators. It is not clear, like it's not like auditory brainstem responses. We have first peak generated from the auditory nerve distal part, second peak generated from the proximal part. It is not that exclusive. So we have multiple generators throughout, and P1 is said to be primarily from auditory cortex, primary auditory cortex, but it can also have some contributions from other cortical areas. Similarly, N1 is reported to having multiple generators. It has like 3 generators. In fact, N1 can be divided into N1A, N1B, N1C, like that. So it has multiple generators there. And P2 is from primary and secondary auditory cortex. N2 again, in addition to auditory cortex, there is contribution from limbic system, reticular activating system, because of which it gets affected more by attention. So this is in very brief about the generators, because the focus of this obligatory cortical evoked potentials right now is more in terms of how we can use it for hearing aid benefit or assessing benefit from hearing aid, because the application of CAEPs in central auditory nervous system disorder, or CAPD, is actually little controversial, or we have equivocal results on that. So like I already said, any research that takes place should come into clinical practice, but then cortical auditory evoked potentials were discovered in 1930s, but even today it's not really so much into clinical practice. People are trying to bring it more into clinical practice, but then it is not so much. One of the reasons could be because initially we were looking into objective method for threshold estimation, and threshold estimation in a difficult to test population. So we were looking into a test where we can put a person to sleep, put a child to sleep, and then test. So ABR had the advantage for it. So ABR became more popular than cortical evoked potentials. And since cortical evoked potentials are affected by sleep and attention, the application of it became limited, because unless a person is active, alert, and we cannot really record good cortical evoked potentials. But it actually does have its application. And another thing I should say is that most clinicians have a feeling saying cortical evoked potential is difficult to record. Because that ABR is easy to record, whereas CAEPs are difficult to record. And I keep telling, whenever I talk to anybody, any clinician, I say cortical evoked potentials are not difficult to record. If you can record a good, reliable auditory brainstem response, you can also record a good cortical evoked potentials. And using the same system, you can do the thing. So we know that cortical evoked potentials can be recorded from single channel, 2-channel, multi-channel, 256 electrodes. And using a multi-channel system for recording cortical evoked potential definitely has advantages where you gain a lot of knowledge from it. But when it comes to clinical application or doing it on a patient who comes to your clinic, then I think we would be happier with single channel or 2-channel recording, which is much easier to do and much faster to do. And cortical evoked potentials can be recorded using just a single channel also. I think the NAL group is now advocating that with a HEAR lab, saying that you can do a single channel cortical evoked potentials and have reliable clinical research from that. So if you look into the history, there are a lot of research going on from 1930s, 1960s. But I think people are using it clinically more after 2000. And my interest into cortical evoked potentials actually started, I should say, in 1996. And truthfully, it started with all my master's dissertations guiding, where we said, okay, we got an Nicole Brevo instrument at ISHA, and then said, okay, we start doing cortical evoked potential using it, get an ALLR normative data for ALLR. It started from that. And when I did start that, I also remember my own colleagues telling me that, oh, I don't like these dissertations which lie on the shelf. And from that sentence, I always made it a point saying that, no, I have to make it clinically applicable. So I may not really have publications like in international journals and all, but then I've always tried to see how clinically we can try to use this cortical evoked potentials and how effectively it will help us in our diagnosis and rehabilitation. So why do we need to use cortical auditory evoked potentials for clinical evaluation? Like I said, it can be reliably recorded from all populations, starting from infants. Sorry. Infants, even though it is affected by sleep, it can also be recorded when a child is sleeping. The amplitude of cortical evoked potentials is reduced when a child is sleeping, but we do get a response if there is a response. So maybe like I wouldn't use in a sleeping infant, I may not use it for threshold estimation, but I can still use it to see if evoked potential, if CAEPs are present or not present. And the second biggest advantage of that it can be recorded in persons using hearing devices. So we all know that the drawback with ABR is that we cannot really get a reliable aided ABR testing. So we do have ASSR to some extent. We have used it, and all of us know the limitations of ASSR. So it's not really something which is recommended so much for aided testing also. So whereas cortical evoked potentials, we do get potentials when we use hearing devices, be it a hearing aid, be it cochlear implant. And we can record it using a range of stimuli starting from simple pure tones to complex speech stimuli. And why I'm stressing on that is I'm assuming that in this forum there are many people who are doing private practice or clinicians in a private clinic setup, not really in an academic setup. So sometimes like you may not have an instrument which can give using which you can present speech stimuli. So at such times you can do cortical evoked potential using tonal stimuli also, and even that does help in both diagnosis and rehabilitation. So later on I do have some examples to show that how we have used it in different setups in this thing. Okay. So basically I can say that there is evidence in literature to show that there is good clinical applications of CAEPs, and evidence-based practice is the buzzword now. So all of us look into say, okay, do we have evidence to say that we can use it in our practice? And my answer for CAEPs is definitely yes. We do have evidence to use it in clinical practice. Okay. So to start off, CAEPs, how do we use it in hearing assessment? Normally, whenever we talk of hearing assessment, the first thing that comes to our mind is threshold estimation, and then comes other applications. So when you talk of the threshold estimation, ideally CAEP is a very good tool for estimating threshold, because when we talk of auditory brainstem response, it checks only till the brainstem. It only checks to the inferior colliculi. Whereas when I talk of cortical auditory evoked potential, it is checking till auditory cortex. And when I use cortical auditory evoked potential, it is easy to use a tonal stimuli which can give me frequency specific information. So it is a very good tool for estimating threshold. But the major drawback, like all of us know, is that the amplitude of CAEPs is affected by sleep. So if a child is sleeping, the amplitude of CAEPs is affected, so the threshold I get will be higher. So it automatically affects my threshold estimation. And most often I am looking into assessing hearing in difficult to test population. So CAEPs is not really a test recommended for clinical use for threshold estimation, unless you are testing an awake adult person, like somebody with functional hearing loss where you want to assess the hearing, then maybe we can look into it. Otherwise, we don't really look into, or we consider CAEPs for estimating threshold or estimating the degree of hearing loss and configuration of hearing loss. The other part of the hearing assessment where CAEPs have been found useful is in persons with auditory neuropathy spectrum disorder. And I'm sure all of you are familiar with auditory neuropathy spectrum disorder, where you have normal otoacoustic emission or normal functioning of outer hair cells, and there is a problem beyond that. So there is a normal auditory brainstem response, and most often we also see long-ringing cochlear microphonics. Now, do we get CAEPs in auditory neuropathy spectrum disorder, or we do not get? So the answer is actually both. We have seen in some patients cortical evoked potentials are present. In some patients, cortical evoked potentials are absent. So now, does CAEPs help in saying whether a person in diagnosing a person with auditory neuropathy spectrum disorder? So basically, what is said is that the presence or absence of cortical auditory evoked potentials may tell us about the severity of dysynchrony. So because it can tell us whether the severity of dysynchrony is more or less, because auditory brainstem response requires highly synchronous firing. And as we go higher and higher, the potentials have larger amplitude, and then we can elicit a response with less synchronous firing also. So generally what is said is that if the EAPs are absent, then it indicates that the severity of dysynchrony is greater. So if I have a patient with ABR absent, CAEP absent, and another patient with ABR absent and CAEP is present, I would say the second patient, the severity of dysynchrony is lesser. And it is nothing to, the studies have shown that it has nothing to do with the audibility. It is just to do with the severity of dysynchrony. So it helps us in judging the severity of dysynchrony. And why should we judge the severity of dysynchrony? It does help us in predicting the benefit from amplification or benefit from cochlear implants like that. So this, the last statement I have is a controversial statement, I know. The presence or absence of cortical auditory evoked potentials correlate with word recognition score. I use the term may correlate with word recognition score because I strongly believe that it correlates, but there are many people who find that it does not correlate and it really doesn't help in predicting word recognition score. But I have seen it many times, it helps us in predicting the benefit from hearing aids. So in other words, even when we think of candidacy for cochlear implants for persons with ANSD, CAEPs may help in deciding. I mean, we all know that whether cochlear implants are helpful in cortical in persons with ANSD is a questionable thing, and first and foremost, it depends on whether it is presynaptic or postsynaptic dysynchrony. And apart from that, cortical evoked potentials can also help us in further saying whether it is helpful or not helpful in LSD. So when we did a study with ANSD persons and persons using hearing aids, we did find a difference in cortical evoked potentials when people benefited from hearing aid and when people did not benefit from hearing aid. For example, the first one here shows a person, an adult, who benefited with hearing aids. So this is not like a perfect benefit, but some benefit from hearing aid. And the second waveform shows of a person who did not benefit from a hearing aid at all. So like this definitely shows that CAEPs are helpful in predicting benefit from hearing aid. And we have done studies where CAEPs have also shown to correlate with the speech identification score. So presence or absence of CAEPs correlates with word recognition score. You all know that word recognition score is determined by many factors, not just the dysynchrony or the severity of dysynchrony, but presence or absence of cortical evoked potentials can be one of the factors which can affect it, which can tell us about the word recognition score. And I have seen at times similar word recognition score, but the cortical evoked potentials are different in two people. And like we've seen it both ways. So just to show an example, like this was a case for a male 30-year-old adult who was referred for cortical auditory evoked potentials and ECOG to our college. And this was because the person was trying to decide whether he wants to go in for a cochlear implant or not go for a cochlear implant. And basically this person had reduced hearing in both the ears. It's an adult onset. and difficulty in understanding speech. He was using hearing aids and there was no benefit from hearing aids as per his records. And we followed the usual protocol of otoscopy, case history, audiometry, auditory brainstem response, otoacoustic emission, and finally the cortical auditory evoked potentials, because that is what the patient was referred for. And this is a typical ANSD where you can see a low mode, loss at low frequencies and lesser loss at higher frequencies, and with very poor word recognition scores, like 25% in both the years. And there was good otoacoustic emission and auditory brainstem responses, but absent with long ringing cochlear microphonic. Actually, the long ringing is really too long ringing. Normally, I would say up to 4 to 6 milliseconds long ringing cochlear microphonic, but in this case, we did see it for a longer time also. And when we did cortical evoked potentials, this was the cortical evoked potentials we got. And actually, I want to tell you, like, all the waveforms I'm going to show here are done using our commercially available normal auditory evoked potential instrument, like it's either Nicolay, Biologic, IHS, or Interacoustics. I have no conflict of interest here, but I just want to say I have not really used Neuroscat for it, I think, and I have not used HearLab also. I know about both those systems only theoretically. Okay, and you can see here that we do have definitely, I wouldn't say good, a better cortical evoked potentials in right ear when compared to left ear. I cannot really identify any peaks in the left ear, whereas we can identify 2 peaks in the right ear. And we have shown here only 2 waveforms, replications of 2 waveforms, but actually this was done with multiple recordings were done to make it this thing. So what do we interpret from this? So this shows that the severity of dysynchrony is probably lesser in right ear when compared to left ear. So what do we recommend based on this? Whether the person wants to go for cochlear implant and take a chance whether he benefits from cochlear implant or not is finally his decision, because ideally reports are not really favorable for adults with ANSD for cochlear implants. But if the person really wants to go in for cochlear implant, then I would say go in for cochlear implant for right ear, because he may find more benefit from that, and the other recommendations are really short. And how do we use CAEPs in, or does CAEPs have any application with central auditory processing disorder? Ideally, yes, cortical evoked potential should be a good test for assessing central auditory processing disorder. But we also know that there are multiple generators for cortical evoked potentials. So because of this multiple generators, what happens is whether we get a cortical evoked potentials or we do not get cortical evoked potentials may not really correlate with the central auditory processing disorders and the other symptoms we see in that. So there are few case reports where we have got abnormal or absent CAEPs in persons with CAPD. So what I've quoted here is published literature, but we do have dissertations done at ISHA where people with central auditory processing disorders, cortical evoked potentials were absent. But in the same dissertation, like I have found, if we have tested 30 people, then like maybe 16 people have absent cortical evoked potentials, whether 14 people will have cortical evoked potentials present. And what does it really depend on is really an enigma. I really don't have an answer for that. And studies say that cortical evoked potentials recorded in presence of noise may be more sensitive in identifying central auditory processing disorder when compared to cortical auditory evoked potentials in quiet. And this thing is there are also studies which say that cortical auditory evoked potentials can help in assessing gap detection ability, because with gaps in noise we can do cortical evoked potential and see what is the gap detection threshold using this. And we have done a study for assessing temporal integration ability. This is long back in 2003. So where we used different duration tone burst and elicited cortical evoked potentials. Of course, it was in awake adults, cooperative adults, normal hearing people. And we did correlate it with the behavior threshold. And we very beautifully, we found a temporal integration factor in this, like the threshold for short duration signal was higher than the threshold for the long duration signal. And this was something very interesting. So it shows that yes, cortical evoked potentials can be used to assess temporal integration ability in persons with central auditory processing disorder. But if you really ask me the choice of test, my first choice of test would be behavioral test for central auditory processing disorder. But if we are not able to come to a conclusion, or we're not able to administer the behavioral test for central auditory processing disorders, then I do go in for cortical evoked potentials. And preferable choice in cortical evoked potentials would be either MMN or P300 rather than just obligatory cortical evoked potentials. And in any case, when we do MMN or P300, we automatically get obligatory cortical auditory evoked potentials also. So this is an example of a person with traumatic brain injury. He was a 25-year-old person who was a left-handed person and had road traffic accident. After that, he complained of difficulty in recalling events, and he basically had like executive memory problem. And when we assessed the hearing sensitivity, obviously was within normal limits. The word recognition scores were good. And we did administer a battery of central auditory processing tests, which showed like majority of the tests showed normal results. Like the screening test for auditory processing showed he's not at risk for CAPD. Duration pattern test was normal. Speech in noise was normal. Auditory memory and sequencing test was actually normal. And dichotic CV test was affected. Basically, in the dichotic CV test, left ear single correct scores were affected and double correct scores were affected. And generally, when we talk of left ear scores affected, we say that if the left ear scores are affected, then there is probably a problem in the right hemisphere. But we also know that dichotic CV test depends on attention, and the selective attention also plays a role in this. So we did administer electrophysiological tests on him, and these are the results we got. So basically, we were able to get P1, N1, P2, but not surely like a very good this thing. And what most importantly, what we found was that N2 was not replicable. The N2 was not repeatable, and N2, we did have a problem in replicating N2. And the amplitude of P2 and N2 both were reduced. Okay, whereas P300 mismatch negativity were all present in this thing. So what probably it shows is that the poor applicability of N2 indicates that probably the auditory attention was reduced in that case. And I correlated that reduced attention to the poor dichotic CV scores we got. So it's been reported that N2 is affected by attention. And if you go by the spoken language processing model, which is given by Medvitsky, he says that selective attention is important for dichotic tests. So deficiency in dichotic test was probably because of selective attention, which I would have normally put it as saying binaural integration deficit in this thing. But going with this, I call it as an attention problem rather than an auditory processing problem. Or in other words, I would say deficiency in attention was leading to auditory processing problem in this case. And probably if we had done it behavior test for checking the attention, maybe I would have got some abnormal results in that also. We have not done that part of it. So basically he was then recommended therapy to improve attention, and then therapy did help him. So this is in brief about assessment part of it. And like I already said, like CAEPs are not very great tools or not the highly recommended tool for assessment. We use it as a last resort in only some cases. And the current trend is using cortical auditory evoked potentials in oral rehabilitation. And I think the next 3 seminars are going to focus more on that part of it, or it is the last 2 seminars are going to focus more on obtaining aided cortical auditory evoked potentials. So when we talk in terms of oral rehabilitation, basically it helps us in checking verification of hearing device, be it a hearing aid or a cochlear implant, how useful is it? It actually can also help us in monitoring plasticity. And again, like I said, it can also help in predicting speech understanding part of it. So for example, just to say, this is a cortical auditory evoked potentials, what you can obtain in a normal person, where you can see all the peaks. And with the same system, same protocol, when we did cortical auditory evoked potentials on persons with hearing loss, this is what was found. And what you see on the left screen is a person with moderate hearing loss, and all these testing was done at 70 dB, 65 dB to 70 dB actually. Okay. And what you see on the right screen is for a person with moderately severe hearing loss. So basically what it tells us is that cortical auditory evoked potential tells us whether the signal is audible or not audible. And I want to remind everybody that when we talk of cortical auditory evoked potentials in rehabilitation, we are not really looking into the threshold of it. I'm not really interested in aided threshold, and we are more interested in the audibility, and most often like the audibility of normal conversation. So this is like as we expect in a person with moderately severe hearing loss, a signal at 60 dB is not audible, so you do not get any cortical auditory evoked potentials. So these graphs I'm putting here to show that yes, there is evidence, clear evidence to show that if you get a response, it indicates that the person is hearing. If you do not get a response, it indicates that the person is not hearing. So when we test people using hearing aids, this is what we have found. Like in a person with moderately severe hearing loss, without a hearing aid, there is no response. But when a hearing aid is put, there is response. So basically it is telling me that yes, there is audibility with a hearing aid. And again, these responses, what I'm showing here is done on adult, where I had proof saying yes, the person was hearing and not hearing. But it implies that this can be used in children to say whether the stimuli is audible for children or not audible, or in other words, whether a child is benefiting from hearing aid or not benefiting from hearing aid can be assessed using aided cortical auditory evoked potentials. And I'm again saying that all these tests are done using this is done using biologic instrument with a natural speech stimuli. So you don't require any extra facility for doing this. But to say that though I put the studies, what we did recently here, by all of us know that aided cortical auditory evoked potentials or doing CAEPs in persons using hearing aid is not new. It actually started in 1960s, where CAEPs were recorded for tonal stimuli. Again, I want to highlight the point here, it was recorded for tonal stimuli. So those of you who do not have facility for presenting speech signal need not think that, oh, I cannot do cortical auditory evoked potential. Yes, definitely the best choice would be using speech stimuli. So if you can upgrade your facility, yes, upgrade the facility to present speech stimuli and then do aided cortical auditory evoked potential. But before that, to begin with and see whether you can record or not record, you can also use tonal stimuli and record cortical auditory evoked potentials. So they did record cortical auditory evoked potentials in infants with severe to profound hearing loss, and the results showed that thresholds for aided cortical potentials were 20 dB better than the unaided threshold. So it is like our functional gain they've shown here, saying that there is an improvement with hearing. And similarly, there were studies done using speech stimuli in aided versus unaided condition. And even here it showed that like when 4 children were tested, 3 out of 4 children showed a benefit with hearing aid. So the P1 responses was better with a hearing aid when compared to without a hearing aid. And apart from the normal obligatory cortical auditory potentials, even mismatch negativity, P300 have also been tried in persons using hearing aids. And I've just quoted a few studies here. Those who are interested can read the literature where there are many more studies. I have not really put all the studies here. So the studies show that use of personal hearing aids substantially improved detectability of cortical auditory potentials in people having hearing loss. So when you compare unaided and aided condition, there is an improvement showing that aided responses will tell us in giving information about how much benefit a person is. So we have done a few studies for these cortical auditory evoked potentials where we did cortical auditory evoked potentials and mismatch negativity in children with severe to profound hearing loss. And we did it with 2 hearing aids, one hearing aid where the functional gain was within speech spectrum and another hearing aid where the functional gain was outside speech spectrum. And the results showed that there was a difference. So when hearing aid, when the aided thresholds were within speech spectrum, the amplitude was larger and latencies were shorter when compared to the other hearing aid. So these are the waveforms which are showing that like when a person is using a good hearing aid, what I mean here is, I don't mean a hearing aid is good. What I mean here is that the aided thresholds were within speech spectrum, and this is with a hearing aid where the aided thresholds were outside speech spectrum. I should actually change this terminology to within and outside. Okay, but I'm sure all of you can appreciate the difference in the waveforms between the two. Similarly, we did try cortical auditory potentials for naturally produced speech sound. So the idea I had in my mind that time was the link sound is what is most often used to check whether a child is benefiting from a hearing aid or not benefiting from a hearing aid. So why not use the same sounds to check whether a child is benefiting from a hearing aid or not using electrophysiological tests. And that time I had not really read about the NIL protocol and those part of it. So we used 3 syllables E, M, and Sh for it, presented at 65 dB SPL, and all the children had severe hearing impairment where unaided we were not really getting any responses, and we recorded cortical auditory evoked potentials with 2 pre-selected hearing aids. Okay, and again it was on a little older children like 5 to 7 years because we wanted to do functional gain measurements to see whether it will correlate or it doesn't correlate. And what we found was like these are the 3, when we checked on normal, these are the waveforms we got for normal children for the 3 stimuli. So you can see that there are distinct P1, this was all using IHS instrument. You can see P1, N1, P2, N2 waveforms. And these waveforms are slightly different for different stimuli. These are 3 different stimuli what we got. And like all studies show, whichever stimuli you use, there is always a significant effect of stimuli on the particular potentials. And when we did it on persons with hearing loss, that is aided cortical auditory evoked potentials and aided behavioral thresholds, when we checked, what we found was that in unaided conditions, cortical auditory evoked potentials were absent, but the responses were present in aided condition. Okay. And the second thing we found was that cortical auditory evoked potentials was better when the child was wearing a hearing aid which had better functional gain. Okay, so this again tells that cortical auditory evoked potentials or your P1, N1, P2, N2 responses do reflect the benefit a child is getting from the hearing aid. I have put it saying at a gross level because I do not really recommend it for selecting a hearing aid. It's basically, it's for verification of hearing aid. So we use cortical auditory evoked potentials for verification where we say whether a child is getting a signal or not getting a signal, not for choosing between two hearing aids. Okay. So now some of the waveforms for this, like this is response for each stimuli. So what you have on the top is the unaided responses. Then you have here aided responses. Rank 1, rank 2 means functional hearing. Functional gain was better for rank 1, functional gain was poorer for rank 2. So subjectively there was a difference in that, and you can see a difference in the waveform also. And similar results were observed for the other stimuli also. So this is for mass stimuli, and this is for stimuli. So we do have a difference between the two. So it showed that the latencies were, there was a difference in the latency and amplitude, and the results actually correlated with the behavioral thresholds. So that is with reference to, so all these studies, whatever I talked so far, tell us whether there is audibility or no audibility when a person is wearing a hearing aid. So that is what cortical auditory evoked potentials basically help us in. So the next question that also comes to us is saying, does cortical auditory evoked potential help us in predicting speech perception or telling whether a child is going to understand speech or not understand speech? And we all know that it is a very difficult question because there are many factors that can affect speech perception. And obviously, obligatory cortical auditory evoked potentials are not the best choice for assessing speech perception. We have to go in for other responses if we really want to. But studies do show that there is some correlation between amplitude of cortical auditory evoked potentials and speech perception. So they say it's been shown that you have your wave morphology is better when the speech perception is good, whereas you have poor wave morphology when the speech perception is poor. And this is being seen in persons with sensorineural hearing loss without hearing aid, and the same thing has also been seen with hearing aid. So we did do a study on cortical auditory evoked potentials and speech perception, and again I want to make a note here saying this was done using tone burst stimuli, because this is the time when I actually shifted from ISHA to Bharati Vidyapeeth School of Audiology and Speech Language Pathology. So when I joined here, we did not have a system which was giving speech stimuli. So, but I said, okay, let's try with tone burst stimuli what we can do. So when we tried with the tone burst stimuli for 1K, 2K, 4K, and we did word recognition score, there was a correlation between aided speech identification score and latency of all the things. So there was a negative correlation, meaning better the word recognition score, lesser was the latency of all the peaks. So it shows that cortical auditory evoked potentials do give us some information about speech perception abilities in the child. These are some waveforms obtained from tone burst ABR, aided tone burst ABR responses. And NAL group has done aided cortical auditory evoked potentials and outcome measures, and they have found that the results of speech or the responses of outcome measured using speech actually correlates with the cortical auditory evoked potential. So that is saying that cortical auditory evoked potentials, the aided CAEPs definitely help us in knowing the outcome of the hearing aid. And the protocol recommended by NAL Australia for CAEPs is using 4 stimuli, MATA, GASA, and they have come up with an instrument called HearLab, which is a dedicated system for aided cortical auditory evoked potentials, I should say. And all of you know the reason behind it. Basically, it's chosen a sound representing low frequency, mid frequency, and high frequencies. And I'm not going to elaborate on this because I think the last in the series, Dr. Mrudula Sharma will be a better person to talk about the protocol used on this and then how they've evolved into this part of it. But taking few from whatever has been reported there, we have also tried for using the 3 stimuli. Like initially we did try with MATA, GA, and then later on we added into it to check how the responses are. And I have to quote the studies, dissertations done last year by one of our students, which showed a very good information or very good evidence to say that yes, cortical auditory evoked potential give us a lot of information. So what he did with, it was done under our staff, Dr. Sharda Sarda's guidance. So he did a subjective and objective verification of frequency compression technology in individuals with sensory neural hearing loss. And so basically he recorded cortical auditory evoked potentials for 3 stimulus. I know we need to do it for 4 as per the NAL thing, but we also have to save time. So because of which we said, okay, let's try it with 3 stimuli. So 3 stimuli, TAGA and SA with and without activating frequency compression. And these were all adults with sloping SN hearing loss who did not really benefit at higher frequencies from a hearing aid without frequency compression. Okay. So when aided responses were compared when the frequency compression is activated and not activated, it was very clearly observed that there was no significant difference in latency and amplitude for TA and GA, whereas for SA responses, there was a definite difference. Responses to SA stimuli, SA, it is not really ARTS, is what was chosen, was present for all participants with frequency compression activated, whereas it was absent when frequency compression was not activated. So you can see an example of the response here. This is CAEPs for TA stimuli. This is for GA. So you can see that without frequency compression, this is without frequency compression, and this is frequency compression. Similarly for GA, without frequency compression and with frequency compression. So you can see that we see clear aided cortical auditory evoked potentials in both the conditions. Whereas when we take stimulus without frequency compression, there is no response, whereas we do see a response with frequency compression. Obviously, if I flip it back and show you, like the responses were better for GA when compared to SA. This thing, but then frequency compression did make a difference is what it shows. And so, and these people were also tested using high frequency word list, and it did make a difference with and without frequency compression when high frequency word lists were used. But this shows that using aided cortical auditory evoked potentials, we can say whether a person is getting benefit or not getting benefit. And whether it's getting benefit in low frequency region, mid frequency region, high frequency region can be said based on the stimuli we use and how we do it. So this is another case. I just put some case reports here to make it a little more interesting. 28-year-old lady who was referred for aided cortical auditory evoked potentials. Again, this lady also was diagnosed as ANSD, and it was not a new diagnosis. It was from failure. She was diagnosed as ANSD, and she was using hearing aid, but she reported that there is no benefit from hearing aid. And again, they had a dilemma saying, should they go for cochlear implant or not go for cochlear implant? And I'm not saying CAEPs are the test to determine whether cochlear implant candidacy, but then when people are in a dilemma, they want to try all the tests. So they just want to see what else can be done. So with that in mind, they came to our clinic for cortical auditory evoked potential, or they were referred for aided cortical auditory evoked potentials. And we did record cortical auditory evoked potentials for TA stimuli. We did with TA because most often we get a good response for TA stimuli at 70 dB SPL. And this is the response we got with a hearing aid. So what it again shows is that this response, this is left ear and this side is right ear. So right ear, all of us can mark this much easily. you can see a replicable peak. Whereas in the left ear, you do see a peak, but it's like questionable peak kind of a thing. So again, it is showing that a person is hearing better in the right ear when compared to the left ear. So here again, I would say if a person is really wanting to go for cochlear implant, then maybe right ear is a better choice than the left ear. Okay. So it says interpretation is aided exogenous cortical potentials are present in both the ears, and functioning auditory cortex with a hearing aid is better with right ear stimulation than with left ear stimulation. So it basically indicates that maybe there is better benefit from cochlear implantation in the right ear than in the left ear. Unfortunately, now both these participants have not come back to me as to whether they went for cochlear implant or did not go, and what if they underwent cochlear implantation, what is the result? I really don't know. I think you should look into that to say whether it is really useful or not. So to summarize, in terms of verification of hearing aids, I can say that definitely cortical auditory evoked potential help us in saying whether a person is benefiting or not. So it is basically the detectability of cortical auditory evoked potentials. I mean, I did talk of latency, amplitude, saying the amplitude is better, latency is lesser. But clinically, if I have to make an interpretation, I would go more by detectability of the responses rather than latency and amplitude, because there are many factors which are affecting the latency and amplitude. A simple thing like I do aided and then I do unaided and then do aided, it is sequential testing. So there are many factors which can affect the amplitude other than just the hearing aid itself. So, but basically I go by the presence or absence of cortical auditory evoked potentials, and the detectability of cortical auditory evoked potential increases when a person is using hearing aid and if it is within, it is benefiting him. Okay. And if you really look into the morphology and latency, most often do correlate with functional hearing loss, with functional gain. And there is some correlation of morphology and latency with aided speech identification score also. So though there are many other factors which can actually affect the speech identification score apart from the audibility part. Okay. So that is two, and I'm sure the next two lectures will have more on the aided cortical auditory evoked potential, so we're not going into the detail of it. A little bit about how useful is cortical auditory evoked potentials in persons with cochlear implants. Cortical auditory evoked potentials are useful in checking for the maturation of central auditory path. So all of you, especially those who are into cochlear implants and into cortical auditory evoked potential, would have read Anu Sharma's studies, where she has beautifully quoted how the maturation of central auditory nervous system can be monitored using cortical auditory evoked potential. So there is also a good correlation between cortical auditory evoked potential and speech perception abilities. Like I said, Anu Sharma et al. Consider P1 as the biomarker of maturation and said that the latency of P1 reflects how the central auditory nervous system is responding. And the latency decreases with age, and it also depends on when the implant was done, because auditory stimulation is important for maturation of central auditory nervous system, and whether the stimulation was given in the sensitive period or after the sensitive period also determines whether there was maturation in the central auditory system or no maturation in the central auditory system. Okay. So if it is not stimulated in the central auditory within the sensitive period, then the auditory cortex can get reorganized, and the studies which showing that there is decoupling of primary and secondary auditory association areas, and the studies which show that the vision takes, auditory cortex starts responding for visual stimuli rather than the auditory stimuli. So it becomes difficult for the auditory stimuli. So whenever there is deprivation because of lack of stimulation, what has been found in cortical auditory evoked potential is a deprivational negativity. That is, you have a negativity before P1, onset of P1 peak, and there is a low amplitude of P1 and the latency of P1 is delayed. And sometimes you don't really see a good P1, N1 or this thing, you see more like what is called like a polyphasic waveform. So you just have waveforms which cannot be clearly marked. And again, those of you who have read into the Anu Sharma's article must be all familiar with this, where it shows that depending on the age of implantation and depending on the age of the subject, the latency of P1 will vary. So those children who are implanted before 3.5 years of age, she showed that can reach normal P1 latency, whereas those who are implanted later, that is after 3.6 years or after 7 years, the latencies did not reach the normal latency at all. So we did a study with cortical auditory evoked potentials in children using cochlear implants, and what we found was we did not really find any correlation between latency and amplitude. Of what I tried to do there was try to see if there is a correlation between latency of P1, N1 peaks, latency and amplitude, and the auditory skills. So we did not find any correlation between the two. But one thing we found for sure was that whenever cortical auditory evoked potentials were absent, the auditory skills were poor. I mean, there were about 3 children who had poor auditory skills, and all 3 of them did not have cortical auditory evoked potentials, whereas the other children, cortical auditory evoked potentials were present. So this is just to show, like, if this is a child we have who has an excellent outcome with cochlear implantation. And you can see that CI assisted cortical auditory potential is also extremely good. I mean, this was done, this child is 7-year-old and implant was done at the age of 3 years. But we can clearly mark all the peaks, and in fact, I could even get a PT100 waveform in this child. This is again another child with cochlear implant, where the age of implantation was 2.5 years. So we did cortical auditory evoked potentials when the hearing age was 3 years 4 months, and you do see peaks over here, and the child is doing well with cochlear implants. And this is a child with cochlear implant. Age of implantation is 2 years 8 months, and cortical auditory evoked potentials were recorded when the child hearing age was 7 months. So you can see that we don't see as good peaks as we saw. I mean, I don't see a peak like this, but then I definitely see replicable peaks coming here. This is a child again whom we recorded cortical auditory evoked potentials with an implant age of 6 months, and the age of implantation is 4 years, and we do see a negativity here. Is it the deprivational negativity? I'm waiting to see whether this will disappear, not disappear, and because what is said by reported by Anu Sharma is that the deprivational negativity can disappear after with stimulation. And you can see here, this is a child whose hearing age was 1.5 years and age at the time of implantation was 4 years. And you can see that the waveforms are really poor. When I do see a peak here, it's not really replicable in terms of latency. And even during therapy, the progress was really not good. And unfortunately, the case did not follow up, so we could not do the testing later on because of personal reasons. This is another case I have where we really don't know what is happening with this child, where this child is a 4-year-old child with a hearing age of 9 months, and the child does not respond for any sound. Behaviorally, the child does have other associated problem also, and psychology says probably autistic spectrum disorder. But if I check electrical, this is electrical stapedial reflex. If I do electrical stapedial reflex, I do get reflexes. So this is a map given based on the electrical stapedial reflexes. But that means ideally the child is hearing a stimulus. Audibility is there, at least at the level of brainstem, and the child is responding. And this is the cortical evoked potentials I get on this child. And we've even done an EABR on this child, and an electrical ABR shows good peaks. So this is showing that this is a child with cochlear implant, where the implant is, yes, is in place, implant is functioning normally. So the child is hearing well at the level of auditory nerve and till inferior colliculi, but there is something beyond that. And all these tests were done on this child because the child was not showing improvement, and the therapist told me that in spite of 6 months of therapy or 9 months, the child did not show the improvement that was expected. So this again shows that cortical auditory potential help us in supplementing and complementing the results. So it tells us, like, it is not that, I mean, like one time you would say maybe the parents are not working at home or the therapist is not doing a proper job, so there is no improvement. So these results show that yes, that those are not the factors. The factor is also that there is a problem beyond or inferior colliculi or a level of auditory cortex. There is some problem because of which the child is not able to integrate the signal and not doing well. So in essence, all these do show that yes, cortical auditory potentials can be useful in clinics, and it should be used in clinics wherever is possible. So and again, I think about the protocol that needs to be used for cortical auditory potentials. We do have the next seminars where Hari Prakash is talking about the protocol, and Dr. Mrudula Sharma is also talking about the protocols, but I've just given in brief here what needs to be done when we're recording cortical auditory potentials. And again, I'm focusing more on instruments where we are doing the normal routine ABR, like Nicolay Biologic, IHS Interacoustics, those kind of instruments, not the dedicated Care Lab instrument or the multi-channel neuroscan instrument. So the stimuli used is, I mean, if you're talking of the aided cortical auditory potential with hearing aid, it is obviously acoustical. If you're talking of cochlear implant, then I can either use acoustical or electrical, though personally I prefer to use acoustical wherever possible because it tells me exactly how the child is hearing. So when I cannot use an acoustical stimuli, when I do not get a good response with acoustical, then maybe I do with the electrical. But then I prefer an acoustical because it does tell me how the processor is processing the signal and then how the child is hearing. So the stimuli used, obviously good stimuli is speech, but if you do not have facility for speech stimuli, you can start off with non-speech stimuli and then upgrade yourself for speech stimuli. And when you use speech stimuli, ideally use a stimuli, or in any case, always use a stimuli representing low frequency, mid frequency, and high frequency so that we get a range of hearing. And the repetition rate is generally 1.1 per second, that is normally used. And the number of sweeps is around 300 sweeps, but generally what I prefer here is collecting smaller samples and then adding it up. That is because what I've seen is that generally when we're doing this cortical potential in a person who is alert and awake, after some responses, the amplitude reduces. So part of the reason also could be, I'm sure Sandeep will talk about it in his next lecture next Saturday, but it could also be because of the alpha waves, because the person becomes drowsy after some time and the response reduces. So for that reason, what I would prefer to do is I'd like to collect cortical auditory evoked potentials in blocks of 50 or 100, and then maybe talk to the child, have a break, and then again record it, and then add everything together so that I have an average for 300 stimuli. Okay, and the electrode montage, like I already said, we have single channel, two channel, multi-channel, and multi-channel can go up to 64, 128, 256. For clinical purpose, we are happy with a single channel electrode. And single channel placement, electrode placement can be similar to how we do auditory brainstem responses. So with non-inverting on vertex or high forehead and inverting on the mastoid and common electrode on the low forehead. That is my conventional thing, normally what I use. And inverting, I generally prefer using it on the ear contralateral side to the hearing device. So if cochlear implant is on the right side, then I would put an electrode on the left side. Okay. And then we have the filter settings. We need a low filter settings and we low amplification will always do. The analysis window, yes, we should have at least, we should be able to record responses for 500 milliseconds. And it is important that you have a pre-stimulus average when we're doing cortical evoked potential. We don't stress so much on the, or we don't really do pre-stimulus averaging when we do routine auditory brainstem responses. But for cortical auditory evoked potentials, it is important to have a pre-stimulus average because that gives us an idea as to whether the response we got is really a response or is it a background noise. So that makes a difference. So generally have a pre-stimulus average of either 50 or 100 milliseconds, minimum of 50, maybe 100 milliseconds, and then 500 milliseconds for the analysis window. Okay. And so that's about the thing. And these factors affecting, I'm not really talking about it in detail, but I just want people to know, I'm sure all of you know, but then just recollect whatever you have read earlier and whatever you know, that there are many factors that can affect cortical auditory evoked potentials, starting from type of stimuli, frequency of stimuli if you're using a tone, which type of stimuli what stimuli you're using, the regression rate of the stimuli, what transducer you're using, and if you're using a speaker, what is the distance, what is the angle. Okay. And it's basically the distance, again, distance from the ear or distance from the hearing device and angle with the hearing device. That's what we need to make sure. And when with reference to factors related to recording, the general factors which we always say, the filter settings, the electrode montage, the artifact rejection we use, number of averages, the time window, all these are the factors that affect recording. And the important factors with related to subject is the age and the state of arousal. Those are the two important factors. I've left out the other factors, but the two, because we all know that to record a good cortical auditory evoked potential, a person should be awake and alert. That is when I get the best cortical auditory evoked potentials. Though, I repeat again, cortical auditory evoked potentials can be recorded in sleeping infants or sleeping adults also. And when it comes to age, we need to remember that if this is a typical auditory brainstem response we get in an adult with P1, N1, P2, N2. In infants, the latency is much longer, and we just see a broad positive peak and a negative peak where P1 and P2 may not be differentiated also. So most of, well, a lot of times people just call it as positive and a negative peak and not really label it as P1, N1, P2, N2. So you should have some normative data or some information about how the cortical evoked potentials are in infants and children before you really start to clinical population. And these are the factors which we normally talk of for any auditory evoked potentials, what I've discussed so far. And when we talk in terms of aided cortical auditory evoked potentials, the other important thing is about the hearing device. And because what happens here is we have an auditory stimuli, which we know what the auditory stimuli is, and we measure the cortical auditory evoked potentials. But in between, there are two unknown things. Most often when I'm doing just an unaided one, it is only the auditory system. I don't know the functioning of the auditory system. So I give a stimuli, I measure the response, and I can say how the auditory system is functioning. But here I have two unknown things, that is the hearing device can also affect the auditory stimuli that is being presented, and then how the auditory system is getting processed. So one needs to be a little more careful by interpreting aided cortical auditory evoked potentials. Okay. So basically the take home message I want to give is saying cortical auditory evoked potentials can be recorded in clinical setting using commercially available auditory evoked potential system, and they do help in assessing difficult to test population, helps in assessing benefit from hearing aid, and it can be used to monitor effects of rehabilitation post implantation. There are also a lot of studies on use of cortical auditory evoked potentials in monitoring the benefit and the plasticity and all that part, which I've not really gone into the details. Okay. So the challenges you have while recording cortical auditory evoked potential is that basically I do cortical auditory evoked potential on children because I cannot do a behavioral measure. I should have a quiet child who is active and alert, but she has to be quiet. So most often I do take help of the therapist. So to do this, so because that becomes easier in that part of it. And the second challenging part is if there are artifacts, how do we control the artifacts? And more often than not, we do have artifacts and we have to make different measures to control the artifacts. And again, this controlling artifacts part of it is going to be the next series, next lecture in the series, that is Dr. Sandeep is going to highlight us about how we can control artifacts and what best can be done. So that's it. I would like to sincerely thank the Clinical Audiology Group and ISHA for organizing this webinar and giving me an opportunity to share my experience. And whatever I've presented here is not just my experience, it's our experience, I should say. And so the credit, if there is any credit to it, it always goes to my colleagues and students at Bharati Vidyapith School of Audiology, Speech Language Pathology, as well as my colleagues at ISHA who helped me in this journey of cortical auditory potentials. Thank you. And if there are any questions, and or we can have a discussion, because I'm sure there are many more experts here. So the other experts can also add on to it or have more discussion.
Thank you, ma'am. This is Niraj now, and we have a few questions, ma'am, from the attendees, and I'll take up a few questions first, and then maybe I'll read out the few questions which people have typed. One of them, I'll go from beginning to the end, towards the end, ma'am. There was one question by Meenakshi Gupta, and she had asked a question regarding in cases with APD, whether you have experienced or read about any studies which talk of improvement in CAEP post rehabilitation. For example, she puts fast forward or any of those kind of rehabilitation has been used, and then CAEPs have been tried before and after.
Yeah, definitely. There are studies where cortical auditory evoked potentials have shown improvement post rehabilitation. Not really fast forward, but the literature goes back to JIRSA in 1970s, JIRSA and Klons where they talk of it. And we also had a project at ISH where Sandeep and me worked on a project where we did therapy and cortical evoked potentials were done pre and post, and there was an improvement.
There is another question by Meenakshi Vadera, ma'am, and she asks, does amplitude of CAEP change with duration of use of amplification?
This again is related to the plasticity. So if you're talking of a child who is given a hearing aid, and then if you like how Anu Sharma has documented with reference to the latency part of it. So similarly, if with cochlear implants, similarly, if a child is given a hearing aid at a young age, and then with age, I would expect an improvement in amplitude.
The next question is from Sri Vidya Balaji. She asked, do we have normative data for infants in India on CAEPs?
Infants in India for CAEP, we really don't have normative data.
There is a question by Raghav Jha. He asked,
there may be. No, I said that is to the best of my knowledge, but I think Niraj, your own study has some normative data, particularly
yes.
potentials in infants.
Yes, ma'am.
So that
I wouldn't call it as normative data because I think the number was slightly restricted, but I did study on infants with normal hearing, infants with auditory neuropathy, infants with auditory maturational delay, and infants with SN hearing loss. 4 groups were there. We had smaller sample in between 10 and 15 in each group, and we do have data of that now.
So there is some, probably what I would say is there is some data, because in different clinics we have different data. Like we have some data here where we have done on infants, but then we don't have to have what is called as a normative data and not a published normative data kind of a thing.
Yes, ma'am. We have another question from Raghav Jha. He asks, Madam, binaural advantage from the hearing aid, can it be seen using CAEPs, aided CAEPs?
Actually, yes. There are studies on it, and long time back, I remember we did a study with, this is when Shrikant Mishra was there. We did a study with cochlear implant in one side and hearing aid on the other side, and then bimodal versus unilateral, and there was a difference in the cortical auditory potentials with this thing. It was at a conference, but then it does show.
Another one is, there is a series of questions by Sri Vidya Balaji. As the data changes with parameters and instrument, how do private practitioners use this to compare?
Well, the simple answer is have a normative. Well, there are 2 options. One, have a normative data for whatever you are doing. The second option is use a protocol which is published and has a normal. So suppose somebody says use dash 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 parameters, replicate it, use the same thing. So because I know it is not easy for a private practitioner to collect normative data, it may not be easy. So in such case, you replicate whatever is already published and use the same things. Then you don't have to have a separate normative data. But if your instrument is not giving exactly the same protocol as what is being published, then you'll have to collect a normative.
And another related part of that is, are there longitudinal studies which show such kind of changes? Because I think most of the studies that you talked also had more cross-sectional, like different age groups and their data. The same children have been followed over long duration. And
one, definitely Anu Sharma's studies on cochlear implants are longitudinal studies. She has a lot of longitudinal studies on it. And even the Chinks group in Australia have done longitudinal studies. I'm not very 100% sure whether it, Dr. Mrudula Sharma may be able to answer on that part, whether cortical auditory potentials for a part of it in that. But here in our University Bharati Vidyapith School of Audiology, I do have information on longitudinal study on case report. Like I have seen cases where the latency has decreased with use of cochlear implant. I have not published the data, but we have seen the difference. And I think also there were some preliminary dissertations where Dr. Madhuri has got some data with CAEPs, longitudinal studies, if I remember correctly. But definitely we have case reports. I don't call it as a data for like a published data kind of a thing, but the case reports where the latencies, there is a change in latency and amplitude with use of cochlear implant.
And In auditory dysynchrony study, better response in right ear. Does right ear advantage has any contribution to it? Shashank Nima asked this question.
We need to do a little large population study to do it, because the couple of patients I have seen the right ear advantage. So, but I cannot really say it. I would say rather we need to do more studies to see whether it makes a difference. Probably it would make a difference. Because actually one case where I just showed you, if you people remember, where the word recognition score was similar, but there was a difference in cortical auditory potential with right ear showing better responses. But
Yes.
obviously with one case study, I think there is a right ear advantage, but it needs to be probed.
There is a question from Sunil Ravi. He asks how the CAEP in post and presynaptic dysynchrony.
CAEPs in pre and post synaptic dysynchrony. Actually, it shouldn't really make a difference.
I feel the same way, ma'am.
Yeah. I don't have any data or any study. I'm just saying from my understanding.
There is another question by Shashank Nema. He asked in 2007 study, madam, you got better response for E. Any specific reason for this? I think he's referring to Shruti's dissertation.
Shruti calls thing.
Yes, ma'am.
I really don't have a very recorded this thing to say why it is.
And Chandan Kumar asks a question. Any correlation in threshold estimation between ABR and CAEP?
I haven't really checked that, and nor have I really come across any studies. Correlation means I would definitely expect a good correlation. And CAEPs.
I remember, ma'am, we recorded a few where we had, because in my dissertation I did ABR threshold as well as LLR threshold. And we found that actually CAEP thresholds were slightly better correlate, means there was less difference between behavioral threshold and CAEP.
It will correlate better with behavior.
Yes, yes.
Exactly. I said there will be a correlation between ABR and CAEP threshold, and CAEP's thresholds will correlate better with pure tone thresholds than ABR. I mean, you see at lower level rather than correlate better, I would say. If you see ABR at 20 dBSL, maybe CAEPs you see at 10 dBSL.
Yes, ma'am. And there is a request from Meenakshi Vadera. Please elaborate acoustical bar electrical stimuli in reference with CI.
Acoustical stimuli, what I mean is we use a loudspeaker when I'm testing a child with cochlear implant. I use a loudspeaker, so the stimulus, the same stimulus what we're using through our instrument is presented through loudspeaker, and then the response is recorded. When I talk of electrical stimulus, what we use is we interface our auditory evoked potential system with the cochlear implant software. So the electrical stimulus, we need a triggering cable for that, which you have. The auditory evoked potential system have a facility for trigger in and trigger out. So I have to be using this triggering from external trigger. So I connect the cochlear implant software system with the ABR system and then do it. And this triggering cable can also be made personally, or it can also be bought from the companies. The companies do have the triggering cable. We have got it from the company. We have got it from Biologic as well as Interacoustics, the triggering cable. And that works fine with, we have basically experience with cochlear and Digisonic, and it works with both.
Then there is a question, ma'am. If an infant comes to clinic, how will the clinician diagnose if the peaks are appropriate using amplitude and latency values? Is it by experience of seeing the wave morphology, or do we have some norms age-wise, normative, age-wise normative?
I think that we already discussed about the age-wise
Yes.
normative. And yeah, partly the experience also counts here about whether a waveform is present or not present.
There is a question from Imran. Do you recommend using automated response detection for corticals like the Here Lab does? It would make it easy for clinicians who get scared of identifying them from artifacts.
You want a frank answer? Then I'm personally not for automatic detection. Be it ABR or cortical evoked potential, personally, I always feel we humans have a better way of looking into the response and saying whether it is a response or no response. Yeah, what he said is right. For a beginning clinician who has a scare saying, I don't know whether what I'm recording is correct or not, an instrument with automatic algorithm may be helpful. But I also have a problem there, I can say, because again, if the instrument, I really don't have any experience with Here Lab, okay? But if the instrument is not detecting the peak correctly, then the clinician should be able to say, yes, this is not correct. So it does require some clinical expertise over there also. Maybe some use Here Lab can answer this question better, because people have used the Here Lab, I think so. You will be able to answer. But
we have a
look into
question
the
from a Here
ABR
Lab
system,
user.
when I
We
look
have
into the
next question from a
ABR
Here Lab
system,
user.
Yeah.
Would you like to comment about Here Lab CAEP equipment which uses M, T and G sounds and recommend to use for aided and unaided responses? However, responses are not well differentiated with reference to different speech stimuli. What is your observation in this regard?
Like I've been saying, I do not want to comment on the Here Lab instrument because I only read about Here Lab instrument. I have not personally used it. Okay, I would definitely agree, or I support the recommendation given by the NAL group of using 4 different speech stimuli for it. And most often, another this thing is I'm always for using a natural stimuli than a synthetic stimuli. Of course.
And with regards
Definitely
to
yes.
this automated thing, ma'am, I always believe that I think automatic detection cannot remove a human identification
Exactly,
of responses.
that's what I'm
I
saying.
think even for a beginning, a clinician who is beginning, I think if we have, if they do good replication, 2 or 3 replications, and then it's not difficult to identify the response.
Correct.
Whether we identify it as P1 or N1 or what, it doesn't matter. If we get a good replicable response, it doesn't matter what it is.
Because a beginning clinician should also know, suppose there is a mistake done by the automated system, then he should know, yes, this, because I've seen this ABR where the peaks are marked when there are no peaks. So
yes, ma'am.
That way, I always for it, or at least you use an automated, but then use your human this thing to say whether it is a response or not.
There is a question from Divya Vadwani. She asks, do we look at changing the intervention approach from audition only to multimodality approach if aided cortical potentials in children who are using CI is poor?
Yeah, definitely, because the example I showed also, that child where I did not get cortical auditory potential, so we switched over to multimodality, and the child did start doing better when we started using multimodality.
I think there is a contribution from Mridula Sharma to our discussion. She says, but Here Lab shows the peaks too. So she's saying she is for Here Lab.
And that's what I said. I have not used here lab, so I don't really want to comment on the here lab because I have not used here lab. So they would be a better people to comment on that.
Yes. And there is a question from Alpana Pagare. How to decide stimulus presentation level for both unaided and aided CAEPs?
Technically here, whenever we're doing CAEPs for this benefit, what we're looking into is whether a person is able to hear normal conversation level. So like how we say for aided testing, always use the 65 dB SPL. That is what needs to be done, and it should be done at the same level for both aided and unaided. So you're doing it 65 to 70 dB SPL aided, 65 to 70 dB SPL unaided.
I think that is an end to all the written questions that they have asked, but we have an option of discussion, and if people want to contribute to the discussion regarding any of these questions, I think you have the option to show raised hand as probably fourth column being seen in fifth column next to the question column. If you do want to contribute to the discussion or ask any question, you can click there. If I see it, I will activate your microphone. And there is one more question from Sri Vidya Balaji ma'am. Meanwhile, I'll take this question. Any application of CEPs in learning disability?
Yeah, children with learning disability do have central auditory processing problems. So we have seen abnormal CAEPs in children with learning disability. And that is again like how I talked about CAPD. Not all children with learning disability have seen abnormal CAEPs. There are some children where I've seen abnormal CAEPs. There are some children where I've seen normal CAEPs. And the same thing goes in the report also.
And there was a question which I had skipped in between, ma'am. Can presentation of stimulus be done using DAI? I was not sure what DAI is. This question is from Meenakshi Vadera. If you understood, ma'am, you can answer. Otherwise, I will activate her microphone and ask her to ask that question.
DI. What did you say?
DAI, ma'am.
I'm sorry, I don't know what DI is.
I think I request Meenakshi Vadera to please activate your microphone is self-muted. You can activate that and ask the same question. The madam is not clear about DAI.
DI, direct auditory input, using the direct input to the hearing aids or the cochlear implants. Like ma'am actually answered
No.
with a special trigger.
Yeah,
she did answer that.
Okay.
Yeah, we can do that using in hearing aids as well.
No, see the stimuli. Whenever I talk of an acoustic stimuli, it has to be through the instrument. So we need to record the stimuli and feed it into a evoked potential instrument.
So the presentation of the stimulus, it can be through the sound field or right. So it can be used.
Yeah, it can be through a sound field and with a hearing device, depending on how you want to check. Whether you want with a direct audio input or whichever way you want the device, you can keep the device that way. That is.
All right. Thank you very much.
There is Mridula Sharma wants to contribute something. I request Mridula Sharma to kindly activate your mic and you can then talk to me.
Hi there, can you hear me?
Yeah.
Yes, you are clear.
That was a wonderful presentation, thank you. My question is really about the learning disability or APD or CAPD population you've seen, and you mentioned that the responses that you observed are abnormal. Could you elaborate on that as to what do you mean by abnormal? Was it latencies were longer or amplitudes were smaller? Yeah.
Like I've been thinking this, the learning disability population in the central auditory processing disorder is a real heterogeneous population. So I have seen responses where the latencies are longer with shorter amplitude. I've seen where there is absence of responses totally.
So that's curious. Why I mean, absence of CAEPs, and I know in literature, including in NAL data, we've got about 15 to 20% who don't show CAEPs, and there's nothing to account for that. Do you have any thoughts on why would cortical responses be absent if the hearing is normal? There's no syndrome, or none that we know of. Why would the CAEPs be absent?
Yeah,
Just
that's
something to think about.
Question to answer, because like, yeah, I mean, frankly, I also thinking about it, because technically if the hearing is normal, and if you are looking into an obligatory response, the responses should be present. Cortical auditory evoked potential should be present if the hearing is normal and we have to get an APR and everything. Why is it absent? I really don't have an answer for that. I mean, unless, because
it's just something
you know,
to. I've read some and I've heard people talk about it, but I've never seen it, so that's why I'm very curious about this. And like you have also pondered, if they don't have a hearing loss, why would CAEPs, which are just a detection at cortical level, as you said, why should they be absent?
Yeah.
Kind of calls a question to the whole concept, that the sensitivity and specificity of it, doesn't it?
Yeah, actually, I was just going to say about it. One of the problem is with, we could say, like, one, we need to think of the specificity of the test, but then it also goes back to me. I mean, I'm really just talking from my other thing, like auditory brainstem response. When we look into, I remember before OEs were discovered, I had cases where ABR was absent, auditory brainstem was absent, and we did CT, MRI, everything, and everything was normal. And in fact, when I sent it to people, they said, no, your APR is wrong. You're using a wrong protocol, or you're doing something wrong. That's why APR is absent. And later on, that was the first case in India to be discovered, I mean, described as auditory neuropathy spectrum disorder. So maybe there is something which is beyond us, which we really don't know. Because at that time, again, my question was saying, why is APR absent when a person with mild hearing loss? And then there's something else popped in. So like that, is there something like that which we are yet to discover? Or is it the specificity of the test? Because there are a lot of parameters we know can affect cortical auditory evoked potential testing.
I mean, yeah, I don't know, but yeah, it's curious. Thank you for that.
Yeah.
Ma'am, there is one question from Sunil Ravi. He asks, ma'am, why can't we use CAEPs for hearing aid selection?
See, hearing aid selection, meaning what I mean to say is that I don't really, at least personally, I don't believe in getting an aided threshold with CAEP. So if I'm looking into a functional gain and an electrophysiological gain to simulate the hearing gain, I wouldn't really recommend. So like say whether hearing aid A is better, hearing aid B is better. So if I have two hearing aid and which hearing aid is better, then I would rather go by a person's word recognition ability to say which hearing aid is benefiting, I mean, which hearing aid should I choose? Kind of thing. So that way I wouldn't really say for selecting a hearing aid, it is more for verification of a hearing aid. Probably Dr. Mrudula Sharma can answer this question better. If you can unmute her mic, I would like to get her response.
She has the option of unmuting herself.
Yeah, I think you can hear me. We haven't really looked at, I don't think anybody's looked at selecting a hearing aid. I mean, I suppose you're asking whether it's going to be a Siemens. Are you actually asking about the type of hearing aid, or are you asking about the parameters of a hearing aid? Is that what the question is?
I think the question is regarding
I think he's asking
choosing
about
between.
You have hearing aid A and hearing aid B.
Yeah.
Right?
See,
I think the question is saying like,
yeah,
I doubt it. A versus hearing.
Sorry. I doubt if you can actually use that for choosing hearing aids per se, but parameters, absolutely. Like we've looked at gains, for instance, low frequency versus high frequencies, and how they impacted our cortical responses for M versus T. That we've done, but keeping everything the same. I mean, in the end, what are hearing aids? You basically, it's not the type of hearing aid that's important. It's the parameters you choose, the compression point, the gain. That's what important. That's important. So we've done it with gain. We've done it with different gains in different frequency bands, but that's where we've kind of stopped.
Thank you so much, ma'am, for the presentation. I think it was a very, very precise and well organized presentation, very informative. My question was about the protocol in India. Because I'm trying to understand the protocols in different countries for infant testing and fitting hearing aids and cochlear implants. Now, I understand that there's a lot of variations in terms of which clinic or which clinicians and which city does what sort of thing. But let's say, assuming that everything goes right and we identify a baby at birth, for example, at high risk and has some severe to profound hearing loss, and then say we wait for 3 months, again do a testing, confirm the diagnosis, maybe 6 months sometimes, just to be very sure, we diagnose the child, and then we say, all right, we have to go for hearing aids first. We trial hearing aids, and the assumption is that we should trial hearing aids for 3 to 6 months before we decide for a cochlear implant. And this is something that we discussed previously on the group, as everybody recalls. So the thing is that when you fit a hearing aid to a 3-month-old baby or a 6-month-old baby, it is hard to just say with behavior only of what the benefit from that hearing aid is, or whether that child will be successful with a cochlear implant. So I think that aided cortical responses are very, very crucial at that part to objectify things, for the parents especially, because they don't know where they're ending up and what the answer to those questions is. And plus the trans-tympanic EABR that Dr. Sunil Dutt and Apurva and all those people are doing. And I'm sure I guess I saw your slide that you do it as well. I think these two tests in combination, the aided corticals and the trans-tympanic ABRs, previously they had the promontory stimulation. I think they add up to a lot of worries that parents have. Clinicians sometimes can be more objective about things. What is your opinion? Shouldn't we have a protocol in India like we have in Australia or now in UK now?
I would definitely agree with you. To tell you frankly, I've been trying to promote this aided cortical evoked potential in India for a long time. And when people listen to me, they say, yes, we should use, but I don't really see people using it in the clinics, because I feel one is like, it's always it's difficult to get a cortical evoked potential. That is the thing people have. But yes, if your Hear Lab is doing an excellent job, then that should at least take over the thing. And that is the reason I kept stressing in this, saying that it is not just an investment also. Even if you do not invest on another instrument, like Hear Lab has to be one more instrument apart from their ABR. And you said I think now they're coming up with ABR along with cortical evoked potential in Hear Lab, then I think people may start using it more. Right now, people also think in terms of monetarily. I have to invest on an ABR, then I have to invest on Hear Lab. That's part of it. But ideally, I would definitely say, yes, we need to promote, and we should be using aided cortical auditory evoked potential, and it has great potentials in judging benefits from hearing aid. Trans-tympanic ABR is not for all cases. Trans-tympanic ABR is required when we want to decide about this presynaptic, postsynaptic, or the presence or absence of auditory nerve in a child. Only then I would go in for trans-tympanic. And like we know, trans-tympanic has this thing where we have to do it under anesthesia, and the risk of stimulating and all those parts. So only when it is really required, we need to do it. But aided cortical evoked potential is such an easy test, non-invasive. That's why I keep saying if you can record an ABR, why not a cortical evoked potential? It's not anything addition ideally. In fact, it gets done faster than an ABR, probably threshold estimation of ABR. So we should have a protocol and we should be using it.
It's
just
good to hear that
from what you spoke, ma'am. Imran, just want to contribute something here. Just picked up from what you spoke, ma'am, saying that I mean it may be useful even when we are deciding about pre-synaptic, post-synaptic, and all. Instead of doing instead of deciding about it using the transtympanic ABR or the PromStim or whatever we call them. I think if we first do a CAEP and we say whether the CAEP is present or absent, and after that decide about that may cut short our number of people.
Correct.
We need not unnecessarily expose more people to those kind of tests.
Yeah. Correct. That is what I recommend here also. So most often when like Dr. Keertane has a doubt about this thing, he refers for cortical evoked potentials, aided cortical evoked potentials first, and then look into the other options.
I agree. I think there should be a protocol that we should have in India as well for neonatal testing and candidacy selection for hearing aids and implants, like we have, in most of these developed countries. I think that's something that I would definitely want to stress. And maybe this group is excellent, like all the elite people in the group now. I think we might be able to contribute something towards a protocol through this webinar.
Yeah, that would be really good.
And I think one of the attendees, Ebin James, wants to ask something. Ebin, if you can please unmute your mic and then.
Everyone, it's a good discussion there. So I was just adding up to what Mridula said. Hello, Mridula. Yes, if a hearing aid is set, doesn't matter which manufacturer you get it from. If you've got it set up at the right protocol and the right setting, it shouldn't matter whether you have a hearing aid from manufacturer A, manufacturer B, or manufacturer C. So it doesn't matter whether you have to compare 10 hearing aids for a child. It's time consuming and it might not work as well. The other thing with HearLab went with Frey Electronics because they were open platform to do electronic engineering. I know they are really trying to get attached with other manufacturers as well. So maybe in future we'll have it available with other brands as well. Everyone here? Sorry, hello?
Yeah, we could all hear. Just, ma'am, would you like to say something there?
I'm sorry, can you repeat what he said?
I think he was just echoing the words of Mridula Sharma, who said that rather than comparing between the brands, we should look at one hearing aid and the setting within the setting. Comparison within the settings is what I think he was trying to emphasize.
I was just saying that if you have set the hearing aid at the right prescription formula and the hearing aids are set at right levels, it doesn't matter whether you compare between 3, 4, 5, or 6 brands.
Correct.
Yeah. And with regards to HearLab protocols available with other equipments, Nal had to go with Frey Electronics because it was an open platform where it was easy to develop with that manufacturer. But I know they are planning to now roll it out with other manufacturers as well.
Okay. I think this right now is not available in India is what I heard.
That is correct.
I think the main hesitation, Ebin, that I feel most clinicians and also academics have with HearLab that we use in Australia is that because the HearLab is predominantly assumed to do automatic detection using the Hoteling's T-square test, which is a statistical algorithm. A lot of academics and clinicians do not believe that to be the right process. Like Vanaja rightly pointed out, that she herself does not fully trust that automated detection process. But if I'm not wrong, HearLab also allows for manual detection side by side to the automated detection. So a clinician can actually see the visual responses, and if they trust the visual responses but not the statistical algorithm, then they can they can just reject the automated detection and just go with the manual process. I feel that maybe they should add up machine learning in that, so maybe that might help build the database of the automated algorithms to improvise it. So
Yeah. What Imran pointed.
Yeah.
The main idea where the Here Lab came into picture was bringing it to clinics and make it easy for others to use it. Sorry, hello.
Yeah, we can hear you.
Sorry, I thought someone else talking, but so yeah. So that was the reason why it was actually launched in that manner with the T-square and all the algorithms behind it. Yes, it is right that it actually displays the peak form, but you're right, you can't actually override the system and peak mark it yourself.
Can I just add the point I was trying to make earlier? We specifically, when the Here Lab was being designed, both Suzanne Purdy, who actually initiated this whole work, she and I, we both emphasized emphatically that we needed the peaks to be seen. We did not want to fall in the same trap that ASSR has because of the 500 hertz bone conduction artifact that can be misconstrued as a response. We specifically asked for that feature, which is why I was emphasizing.
It's really good if you can see the peak and mark it, because I think the same thing goes back to Algo also. When Algo was first invented, the first system had only automatic detection where there were a lot of problems. And then they came up with detection of visual identification of peaks or visual display of peaks as well as automatic detection for the Algo ABR. The same way Here Lab has visual display, and I would say, I think I just heard saying that you cannot mark the peak visually, right? I would say if you can give the option of marking the peak also, like there is an automatic detection and I do not agree with it. Do I have an option of changing it?
Yeah, it doesn't have an option where you can actually change the peak that's been.
I think if you can make that, it will be, I mean, I would be happy.
Can be, I can actually send that information up for sure.
Yeah, I don't think it should be difficult.
I think Mridula is the best person to answer this, because she's worked from the infancy stage of Here Lab. If maybe there was a discussion about this earlier, in order to give some manual control to the clinician.
Not quite. I think the whole idea at the time, as Evan was saying, was so that there is no question of delay in its usability. The idea was we're developing this this machine so that you can see it, you can see how it's calculating and deciding whether the presence, whether the CAEPs are present or absent, because that's pretty much what it's doing. It's telling you, I mean, they're babies, so they only have a P1, right? So you're basically making a decision whether the P1 is present or absent. So it's a pretty simple paradigm.
That's right. And I think we previously discussed a couple of studies where they've actually compared, visual manual detection of peaks in infants with NeuroScan compared to Here Lab, the automated detection of Here Lab. And apart from a slight difference in latency and a few small morphological differences, there was not a lot of difference. I'm sure there would be a lot of studies previous to the birth of Here Lab that would have been done by Nal and Suzanne and Harvey, where they would have actually asked clinicians to actually manually detect, like experienced clinicians, to manually detect waveforms on NeuroScan or the best systems available at that time, and then compare it with the automated detection. and then there shouldn't have been any significant differences. So maybe once the clinicians, elsewhere, like in India, for example, they start doing such studies and publishing it, and that's probably where the trust will improve as well.
And can I just say how we presented this to Evoke Potential Conference? I believe some people are coming there too. Javi actually said that the machine was better at detecting the peak than the clinicians, and created a little bit of an uproar among the clinicians and researchers.
I think that depends upon the training of the clinicians.
That would depend on the expertise of the clinician.
Exactly. I think that's true for all kinds of areas, not just to the CAEPs.
Yeah, that's correct. Yeah. Because even
I've looked at people saying in MRIs, I've seen people say MRI has got 100% sensitivity for detecting small tumors. But I have seen a few cases where MRIs said that there is no space occupying lesion, but it was only a misinterpretation by the person who interpreted it. MRI always showed that tumor, and it was interpreted by another person as saying, no, there is a small tumor. So I think that's to do with all kinds of areas, not just CAEPs.
Yeah.
I think
totally agree.
I think what Mridula pointed out was right. So now at the moment, HearLab actually does a couple of things statistically. One is presence of a peak at a predetermined area or where it should be, and it also gives you an idea of how the noise flows and how the waveforms are running. That's the EEG part of it, without actually squinting your eyes through the EEG. So if you have to make it a system that's easily accepted by anyone who is not into EPs or not used to seeing EEGs and interpreting waveforms from that, you need to make the system simple enough. Otherwise, people wouldn't adapt it.
Yeah, there is. We are running short of time, so we'll take up this one last question by Srividya Balaji. And probably she wants Mridula and Ebin to answer this. The automated detection by HearLab is based on AI and ML. Any idea where the data was fed for this automation?
I think Mridula would be the right person to answer this. I'm not really 100% sure about the full data behind it.
I'm trying to remember, but I'm not. When you say you want to know about where it was fed, are you talking about? Are you asking about the statistics that was used, or I'm not really sure what you're asking. Sorry.
Srividya, can you please unmute your mic and ask her directly? It may be easy for her to understand. I think she writes a clarification. I mean, which population?
Oh, so they were both a normal hearing and children with varying levels of sensory neural hearing loss.
I think she means whether it was Australian babies.
Yes, the study was done in Australia.
Yeah, it was done in Australian hearing, and the data was actually picked up from Australian hearing database, yes. But it could be a combination for everyone, not just Indian or Australian babies. Could be everyone, a group of people.
Eben, you mean the migrants here as well, right? That's what you mean, but the population is from Australia.
Yeah, community, yes.
Yeah, got it.
Okay, so I think we still may have a lot of questions, and ma'am has stimulated a lot of areas in brain for people to think, read, and maybe come even more prepared for the next webinar. But at least for the time being, we are running out of time. So I would like to really thank Madam first for giving such a wonderful presentation. Ma'am, we are having a lot of feedback on the group saying that they really were very happy with your presentation. So thank you very much for that wonderful presentation. And we will wait for the next webinar. And I think I would like to thank all people responsible for this entire webinar series that we are going to have probably at the end of fourth webinar. We'll conclude it now, and I'll just end it. Thank you, madam, and thank you everybody else for listening and asking your questions. That cleared a lot of doubts in everybody's mind. Thank you.
Thank you everybody for listening and for the discussion.